Okay, this was a really good topic for me to be assigned because we don't think about integrase inhibitors definitely always in salvage, maybe for certain types of resistance, but this is really the question posed by this talk. And so I'm actually going to go over first what's the evidence of using integrase inhibitors in the setting of viral resistance and of whatever type. We'll go over all the data. And then based on that, what's the role of INSTIs in salvage ART? So, when we looked at the first clinical trials for the two major, what are called second generation integrase inhibitors, bictegravir and dolutegravir, I know you don't use bictegravir here. We use it a lot in the US, but it was studied really only in naive patients in 2 studies, and then in suppressed patients as a switch strategy, and not a lot of, really no resistance was allowed in. But dolutegravir was studied in a very different way. The trials in naive patients were called Single, Flamingo, and Spring 2, and naive patients shouldn't have resistance, or if anything, maybe a little transmitted resistance. But was dolutegravir ever studied prior to its release in drug-resistant patients? And actually it was, and there are 2 major trials that show us how to use dolutegravir in resistant patients. The first one was called the Sailing Study, and this was prior to the approval of dolutegravir, that it was studied in comparison to raltegravir in patients with NRTI resistance, NNRTI resistance, PI resistance. The only caveat is there was no integrase inhibitor resistance in the Sailing trial. And dolutegravir was superior to raltegravir in the face of NRTI resistance. Just like the talk we just had, raltegravir has a lower genetic barrier to resistance, dolutegravir has higher, and if you're going to have NRTI resistance, you want to use dolutegravir as your agent. But the Viking study was actually really important because the Viking study examined dolutegravir even in the context of integrase inhibitor resistance. So patients had multiple degree of resistance, NRTI and NRTI PI, and even integrase inhibitor resistance to raltegravir or elvitegravir. And the dose for dolutegravir that was used in the Viking was 50 milligrams twice a day, so doubling the dose. And it was really this study that revealed what Dr. Diaz just said, that Q148 was really the signature mutation of dolutegravir. If you had a Q148H, especially if you had 1 or 2 mutations on top of the Q148, dolutegravir was not effective. However, if you didn't have those mutations, with maybe 1 or 2 mutations, N155, E92Q, actually dolutegravir twice a day worked very well. So this is laying the groundwork for the use of double the dose of dolutegravir in salvage therapy. And then now, over the last 2 years, there have been 4 major studies that looked at dolutegravir in the face of NRTI resistance, now that we're using dolutegravir as the most prevalent INSTI worldwide. These 4 studies were called the Dawning, the Nadia study, the Vicend cohort, and the 2SD study. And I'll go over them in a little bit more detail. The Dawning study was a very specific design, which is essentially looking at, in sub-Saharan Africa, participants who had NRTI resistance, and it was comparing dolutegravir versus PI-based regimens, protease inhibitor, atazanavir, or lopinavir, really. And essentially, dolutegravir was consistently superior to those older generation, this is not darunavir, but those older generations protease inhibitors like lopinavir, ritonavir. But importantly, and we see this a lot, if there were failures with dolutegravir, there were actually 2 failures with emergent INSTI resistance, as we just talked about. That can happen with dolutegravir failures. You can absolutely get dolutegravir resistance. But in the lopinavir arm, just like all boosted PIs, no PI resistance. It really shows you what high genetic barrier resistance there is in protease inhibitors. But because they're better tolerated, because it works well with NRTIs, dolutegravir works fine with NRTI resistance, and it's considered both first-line and second-line therapy worldwide. The Nadia study was a study conducted in Kenya, Uganda, and Zimbabwe that actually looked at after failure to an efavirenz-based or nevirapine-based regimen and an RTI-based regimens. And there was an assumption, and indeed this played out, that there were high rates of NRTI resistance if you failed on NNRTI therapies. In fact, there was 50% K65R in these participants in the Nadia study, which is, of course, a TDF-associated mutation. But the comparison was between dolutegravir and darunavir-ritonavir, with 2 NRTIs. And despite having the K65R, by the way, the investigators knew there was a K65R and they had the choice to use AZT3TC with a K65R. But despite the K65R and high rates of M184V, which was 86%, dolutegravir showed very high rates of virologic suppression, really essentially the same as darunavir-ritonavir. Now, this last line is important because I think it again speaks to the genetic barrier of resistance and the relative genetic barrier to resistance with darunavir and dolutegravir. Of course, there were high rates of virologic suppression on dolutegravir, but if you failed, 9 participants did develop INSTI mutations. But of the failures in the darunavir-ritonavir arm, 0 mutations to darunavir. So we, in our clinic at Ward 86 in San Francisco, we use darunavir actually preferentially for patients who have a hard time taking pills every day. If they have inadequate adherence, we think we can get away with not developing resistance to darunavir over dolutegravir. What about the Vicend study? Well, this was an open-label study in Zambia, and it randomized people living with HIV who switched from NNRTIs to dolutegravir after they were failing. So again, we assume NRTI resistance. And the same effect was seen, that there were high rates of virologic suppression on dolutegravir and tenofovir XTC, even after failing NNRTIs with high rates of presumed NRTI resistance. This is important because the older PIs just don't work as well, not likely because they don't work, but because they're harder to take. And then finally, this is the only study that I've mentioned that isn't yet published. This is a randomized study in Kenya called the 2SD study. And these are actually switching treatment experienced people with HIV from PI-based regimens to dolutegravir. So they were virologically suppressed on second-line ART with PI ritonavir, but if dolutegravir is going to be second-line, can we switch them over to dolutegravir? And there were high rates of continued virologic suppression when switching patients on second-line darunavir-based therapy to dolutegravir-based therapy and no treatment emergence. So these are really the 4 studies, along with the DEFT study that was covered this morning, covered right before lunch, that actually looked at possibly the superiority of darunavir-ritonavir and dolutegravir in the face of NRTI resistance than either dolutegravir or darunavir alone. I will say that WHO evaluated the DEF study at CROI and decided not to put darunavir-ritonavir plus dolutegravir as second-line therapy on their guidelines because dolutegravir works so well with 2 NRTIs, even in the face of resistance, and we really want to save darunavir-ritonavir for when it's needed. And I agree with that decision. So briefly, really, I just told you a lot of studies that looked at dolutegravir in the face of resistance. This is your main INSTI here in Brazil. This is really a lot of confidence building that dolutegravir can be used with NRTI resistance and that it's both first-line and second-line therapy worldwide. You don't use bictegravir here. We use it in the US. And I will say there is not as much data with bictegravir in the face of NRTI resistance. There was a study that was just published just a month ago, in May of 2023, that was a clinic-based study. And this looked at 50 patients who had different amounts of NRTI resistance, ranging from 1 resistance-associated mutation all the way up to 8, and of 50 patients on BIC, TAF, FTC, essentially all of them suppressed. And then there was a study that was published that looked at the 2 switch studies that I mentioned at the beginning of the talk, studies 1878 and 1844, who had switched patients from either boosted PIs or dolutegravir, abacavir, and 3TC over to BIC, TAF, FTC. And the study actually looked at historical genotypes and GenoSure archives, and even in the face of NRTI resistance, of which there was a 16% prevalence, there was almost full rates of virologic suppression. So this is as close as we get. These were, again, sometimes GenoSure archive resistance. And then there was a study that was published that looked across 6 trials. This was in CID, and this looked, this was in AIDS, and this looked at 6 trials in which, again, those same BIC, TAF, FTC trials that I showed you at the beginning, they happened to have, looking across 1825 participants, a prevalence of M184V of 10%, and 98% of participants, even if they had the M184V, stayed suppressed on BIC, TAF, FTC. So the TAF is enough, at least, with the BIC to keep the virologic suppression even in the face of an M184V. So I will say that if we want to really think about INSTIs in Salvage, we have to think about where we can use them. I do actually make the infectious disease fellows at UCSF memorize 12 mutations. I think we've lost the art of memorization, and I think that it's good to have these on your in your head. And so the ID fellows at UCSF do memorize the 6 TAMs, which are M41, D67, K70, L210, T215, and K219. And they memorize those 6 mutations, and then they memorize the K103N, which is the efavirenz nevirapine mutation, the Y181C, which is more associated with the traverine resistance, and then E138K, which is the signature rilpivirine mutation. And then everything else, we obviously look at the Stanford resistance database, but I also have phone contacts in my phone, and you're welcome to get my phone number, and I will send you these. I have a darunavir contact with the 11 darunavir-associated mutations. I think those are important to have at your fingertips to look and say, when can I use darunavir? And I'll give you a slide at the end that shows how many mutations you're allowed to still use darunavir with in Salvage. I also have a lenacapavir and a doravirine signature mutations. So one thing I want to mention about bictegravir is that we have already determined, the Viking study really allowed us to do this, that the Q148H is really the signature mutation for dolutegravir, upon which especially if there are other mutations, it's really impossible to use dolutegravir. Do we have a signature mutation identified for bictegravir? Well, there was one study that looked at the Q148H and a G140S. Actually, this particular participant with both these mutations happened to sneak into one of the clinical trials, and there was a long period of suppression on bictegravir, even with that combination. So it's a single case report, but it does look like it works against Q148, and this was also in vitro. But it seems like there are increasing case reports of a certain mutation associated with bictegravir resistance, which is the R263K. This was a case report of a patient who had HIV and neurologic disease and really wasn't taking the BIC, TAF, FTC on a daily basis, first got an M184V mutation, and then developed R263K, and virologic failure ensued. There are 2 other case reports published, one in Germany, same idea, low adherence, and high viral load, first got an M184V, then got the R263K and failed. Another published case of the same R263K, and then we had a case at Ward 86, the same idea, poor adherence, got an M184V, R263K and failed. So we do not use bictegravir if there's pre-existing R263Ks. What about cabotegravir resistance? I really appreciated the coverage of our study at Ward 86 that we are using Cabotegravir and rilpivirine in viremic participants. Actually, the publication that was shown this morning, we have an updated publication as of July 4th in Annals of Internal Medicine of 133 patients at Ward 86 on cabotegravir and rilpivirine. Now we have about 220 patients who started on cabotegravir and rilpivirine since we've gotten treatment, and about half of them were viremic, and the majority, about 98%, are virologically suppressed. But the main clinical trials that led to the approval of cabotegravir and rilpivirine, and I recognize you don't yet have this in Brazil, were always done in patients, in participants who were on oral ART, virologically suppressed, and then switched over to the cabotegravir and rilpivirine. The FLAIR study was the study done in treatment-naive patients, and the ATLAS and ATLAS 2M. ATLAS is every 4 weeks for the cabotegravir and rilpivirine. ATLAS 2M is every 8 weeks at a higher dose. Those were also done on patients who are virologically suppressed. So what do we know, or can we guess at signature mutations for cabotegravir? Well, actually, there were failures. There was about a 1.4% virologic failure rate across the 3 clinical trials. This was a CID paper that was updated and published in May with Chloe Orkin as the first author. And of those 1.4% risk of failure, you can see the mutations that have come out that if there was failure on cabotegravir and rilpivirine, which mutations emerged. And these are not unfamiliar mutations, right? Q148, G140, R263K, N155. And then there was kind of these are commonly mutations that aren't going to help us if we want to use dolutegravir, for example, as our next line therapy. But another study that would help us determine, and the next talk is on these 2 studies, so I won't really go over HBTN 083 and 084, but it was the resistance mutations in the seroconversions of these PrEP studies that will also help us determine which are the cabotegravir-associated mutations. So HBTN 083 and 084 looked at cabotegravir every 2 months in women and men respectively, for preventing HIV, and the trial results are shown here. But what I really wanted to show you was that this paper that was published in April of 2023 from antimicrobial, from AAC, shows us which mutations were associated with cabotegravir failure. When patients failed on cabotegravir as PrEP, which INSTI mutations came out. And you can see, again, a lot of our E138s, Q148s, N155, L74I, which is associated with HIV subtype A1 and A6, which is found more in Eastern Europe, was associated with failure on cabotegravir. That may be the mechanism by which A1, A6 doesn't work very well, because there were 3 major reasons for failure on cabotegravir and rilpivirine. One of them was the HIV subtype. One of them was having a high BMI. And the third was having rilpivirine-associated RAMs. But these will help you determine what we think are signature cabotegravir mutations when you end up getting cabotegravir in the future, which I heard is, I hope soon, at least for PrEP, and then eventually for treatment. So based on this, what is the role of INSTIs in Salvage ART? Well, I think based on the data that I just shared, I think we can say that you can use dolutegravir with NRTI resistance. We have Vicen, Nadia, Donning, 2SD, we have Sailing, we have Viking. We have lots of data on using dolutegravir with NRTI resistance, and it's a good drug. We have less data actually with BIC-TAF-FTC, but on the other hand, BIC-TAF-FTC has been out since 2018. There's very low rates of failure, so probably it also works with NRTI resistance. You can use dolutegravir with INSTI mutations, but don't use it with a Q148, especially with more mutations than that, and double the dose if you have INSTI mutations. Maybe you can use BIC-TAF-FTC with INSTI mutations. Again, we have 1 case report, but don't use it with an R263K. And then finally, cabotegravir, which I hope will come to Brazil soon, it does have some signature mutations, and we're going to have to take our clues from the prevention trials to give us the idea of those mutations. So in general, I would say INSTIs have a role in Salvage, but certainly not as big of a role as darunavir and the newer agents for multi-drug resistant HIV. And I have very little time left, but I do want to show you this one figure, which I think never ended up in a paper, but it was presented at the drug resistance workshop a long time ago in 2009. I think this is a very important study because it shows you when you can use darunavir. You really can use, when does darunavir, in the face of a darunavir-associated mutations, still have activity? And if you have 0 to 2 mutations, there's still 50% activity. If you have 3 mutations, there's 22% activity. You will want to double the dose of darunavir. You'll want to go up to 600 BID with 100 BID of ritonavir. But once you have 4 more mutations, darunavir-associated mutations, darunavir is not going to work for you. And so I think this is an important stratification of when you can use darunavir if you have a lot of PI mutations. And then what we use there, and I won't go over this data, is we have Maraviroc, if it's a CCR5 tropic virus, for salvage therapy. We have a drug, which is a new attachment inhibitor called fostemsavir. And then we are lucky, we do have lenacapavir that has been approved in the United States since December of 2022 for multi-drug resistant HIV. And I won't go over that data for this talk until I can come back after you've gotten lenacapavir approved. So thank you very much.